All right, so let's do some final exam tutoring. So our topics are going to be substance use, emergency care, skin disorders, and burns. Substance use. We have CNS depressants, which is our alcohol, our barbiturates, and our benzodiazepines. We have our CNS stimulants, which is our caffeine, our nicotine, our cocaine, our amphetamines, meth, things like that. So remember, CNS depressants are going to make us more sleepy. Everything's going to go down, where CNS stimulants, everything is going to go up. Benzodiazepines are going to be your drug of choice for alcohol withdrawal, because with withdrawal, remember, that can be deadly. So we want to make sure if someone's at risk for detoxing from alcohol and going through withdrawals, we want to make sure we give them benzodiazepines. Okay. Another thing we can do for alcoholism is naltrexone. It helps with decreasing cravings to prevent relapse. This is not given during withdrawal. This is given once we've gone through withdrawal and to help us stay off of alcohol. We have when we're assessing alcohol, we have our CAGE assessments. Have you ever feel like cutting down? Have people been annoyed? Have you ever felt guilty or bad? And have you ever had to drink things first thing in the morning to get rid of a hangover? Okay. When we have someone who takes benzodiazepines regularly, they can go through benzo withdrawal. And that's going to be tremory, anxious, psychotic. They're not going to be able to sleep. They're going to be tachycardic, seizures, and hypertension. So when you're withdrawing from benzos, it's going to do the opposite. Same thing as if you're withdrawing from alcohol: tremors, irritability, anxiousness, hallucinations, things like that. Okay. A big thing with alcoholism is we have a thiamine deficit, which can cause that Wernicke's encephalopathy, which is a brain disorder caused by thiamine deficit. So we would, of course, want to give thiamine. And we want to make sure that we're using our therapeutic communications, helping with coping mechanisms, vital safety communication, a low stimulus environment, things like that. And then as far as alcohol goes for the abstinence, so we already talked about naltrexone. We also have disulfiram, which is our aversion therapy. So let's look at our emergency care. So there's a couple of things in here. We have our ABCDE. Y'all know ABC: airway, breathing, circulation. D is disability, and E is exposure. When working on a on scene car accident or something, we are protected by the Good Samaritan law. When we are dealing with frostbite, we have first degree, which is going to be that superficial numbness and edema. Second degree is going to be that partial thickness with milky blisters. Third degree is going to be full thickness hemorrhagic blisters. There may even be black eschar on it. And fourth degree is going to be down to the bone. Okay. When someone is going through hypothermia, if they stop shivering, that is very bad. Okay. When someone's dealing with hypothermia, we want to make sure we're bundling up them in warm clothing, warm blankets, things like that. Yes. All right, heat stroke. So heat stroke is, of course, when we are too we overheat, especially outside in the summer. So a big thing, if you're going to a place that's hotter than what you're used to, you want to make sure you acclimate yourself to the weather. We want to make sure that we limit the time spent during hot periods. We maintain our hydration with water. That's the only thing to help keep us hydrated. Eat appropriately and rest. We want to make sure our heart and our muscle strength is good. If someone is febrile, they're hot, when they're in the room, the first thing we can do is kind of take their clothes off, and things like that, because our skin is going to be our biggest thermoregulator. Bleeding, if you come upon a emergency scene and someone is heavily bleeding, we want to use direct pressure or pressure bandages and elevate the injury if there's nothing broken. We may need to use a tourniquet if the bleeding cannot be stopped. As far as scene safety goes, you never move an injured person unless they're in more danger. So if someone's in water, if somebody is, they're in a car accident, they're on the ground and there's gas leaking, things like that. If they are in more danger where they are, or if they're in the middle of the road and a car is coming, if they're in more danger where they are, we move them. If not, we leave them be. For radiation, we want to make sure that we know our radiation sickness, which is from too much radiation. It causes cell death, nausea, vomiting, fever, hair loss, diarrhea, and of course can lead to death. You are radioactive. We have to take those radiation precautions. Carbon monoxide poisoning. Remember, telltale sign is poor oxygenation and those cherry red lips. And then go bag is something we're going to use during evacuation. It's a bag of stuff that you would need. Okay. So, skin disorders. So we want to do our skin assessment, which is going to be color, moisture, temperature, turgor, edema, lesions. We want to look for skin tinting, which is a sign of dehydration. Herpes simplex is those cold sores. They typically happen on the lip, at the crest of our lip. Of course, skin cancer, biggest risk is going to be sun exposure, UV exposure. For skin irritation, oatmeal baths are not going to treat, but can relieve itching, especially with the pruritus, the rashes, urticaria, any of that. And then as far as our pressure ulcers go, just know your difference between stage 1 is going to be that red, non-blanchable. 2 is going to be dermis, partial thickness, which is typically going to be pink or red of a wound bed. Stage 3 is full thickness. We may have a visible bone or tendon. We may have subcu fat visible but not bone or tendon. And then stage 4 is full thickness, where we can see the bones, the tendons, and the muscles. And then, of course, unstageable, where it's too dirty, it needs to be debrided. We cannot tell what it is because there's so much debris in there. Right. Burns. So burn staging. We have our burn assessment, which is going to determine a burn depth, the type of burn, the body surface area, things like that. As far as our burn staging, we have it's very similar to pressure ulcers. One is going to be epidermis with erythema, but everything's pretty still intact. Stage 2 is going to be dermis and erythema and blistering. And third is going to be deep, painless, because we burned through all of the nerve endings. It may be white charred. The edges are going to be surrounded by second-degree burns. Okay. Looking at our assessments, we kind of already talked about that. Our complications of burns is going to be hemodynamic instability. We can go into hypovolemic shock, which is burn shock, respiratory system dysfunction, lung injury or airway injury from smoke inhalation, sepsis, things like that. So going back to our emergency section, when we are in shock, we need to look at things like our mean arterial pressure, because we're not going to have blood flowing to the tissues as well as we should. When we are in septic shock, we want to look at our lactic acids, our prolactin, and our WBCs. So those are all complications of our burns. Of course, we can have our smoke inhalation, which is going to look like tachypnea, dyspnea, coughing, dark black sputum with maybe soot in it, adventitious nose sounds, irritated eyes, singed facial hair. That's going to be another assessment piece. And then you want to know your rule of nines. So that is where your anterior and posterior head are 4.5 each. The whole head is 9. The back is 18. The front is 18. Each arm is 9, front and back together. They're 4.5 for each side. Genitalia is 1, and each leg, both sides, is 9, so 18 for a whole leg. There are sites that you can go to practice your rules of 9 math, and I will link that as well when I post this tutoring.